So, well, it's a huge subject, so this is a tiny part of it, but the part of this is actually to go out and say, go and find the evidence, go and look at the NICE guidelines and start treating it again. You know, we ask these questions and then we don't treat it, or we avoid asking the questions. Any falls clinic that doesn't routinely ask about continence is not a proper falls clinic, in my opinion. So LUT symptoms can be divided in storage and voiding. Both those storage symptoms and voiding symptoms can lead to problems with urinary incontinence. It's in itself an important cause of morbidity and mortality. You know, if you become incontinent after stroke, after fractured neck or femur, after you've had a serious fall, if you become incontinent in the hospital, your outcomes are worse. And yet we still don't treat it. It's a significant and reversible cause of particularly nocturnal falls and fractured neck or femur, so it may very well kill you. So when people say, well, things like continence don't matter because they don't kill you, well, they might. They might not kill you directly, but they certainly have a contributing factor. An overactive bladder is the commonest cause of lower urinary tract infections and urinary incontinence with age. And it gets more common with age, but it isn't an inevitable consequence of ageing. And that's a message we try and passionately get across. The baby boomers aren't going to accept being incontinent. The 80-plus generation will mention it in passing and be terribly surprised that you can do anything about it. It's a fantastically massive burden to happen to the individual and carers, and all frail patients come with a carer attached if they're lucky. And the cost to the state, both directly and indirect, are massive. There's a cost to not treating continence, so that NICE have said that even any form of improvement is cost effective rather than leaving that person incontinent. But there is no one-size-fits-all in lower urinary tract symptoms, and multiple organ pathology is usual in the fail. And we know as geriatricians and general practitioners that the environment and functional status is more important than absolute matters of normality. So continence treatment fits with comprehensive geriatric assessment, it fits with patient-related outcomes, and it is our responsibility to treat it again in all branches of when we can meet frail older people. There's some papers that I've been involved in an international study called TAC3 that actually shows that it doesn't matter where the patient with continence is treated. If they're an old person, they appreciate being treated as part of comprehensive geriatric assessment. So it doesn't matter if a urologist does it, it doesn't matter if a gynaecologist does it, it doesn't matter if it's a general practitioner or a geriatrician, but they get better outcomes and they get more out of their treatment if we treat it as part of a functional whole rather than just concentrating on the bladder. And that's what we do, that's our bread and butter. Well, containment is expensive. If you look at your local PAD budgets, we spend a huge amount of money on containment. Any improvement will reduce that containment cost. And any improvement, any assessment on any patient, even cognitively at the end of their life, if we use the right containment product or use some toileting strategies, we will reduce costs associated with that. If you are wet in hospital, either because of something we've done to you or because you're incontinent anyway, you will have a longer length of stay. So that's a direct cost. The institutional costs and carer burden costs associated with continence are high. And it goes back to what the last speaker was saying. Yeah, we have to front load healthcare to stop the massive costs of social care. And there seems to be a divorce in government that the two things are actually related, that actually avoiding 24-hour care is a good thing economically and for the patient. Outcomes are always worse in those with urinary incontinence. To treatment is always cheaper. Complicated catheter-associated UTI adds £600 to the length of stay. A complicated one, and that's a catheter-associated infection with any symptoms whatsoever, is upwards of £3,000. So this is why it's a government target to reduce catheter-associated UTIs and a sequin target, which Barnsley have hit, not surprisingly. So what happens personally? Well, if you accept that if you get older, you get wet, you don't go out because you're the smelly old lady that you don't want to meet on the bus, and you lose your friends. You have an increased falls risk, especially at night time. Especially, all of us go to the toilet half asleep at night time. If you're wet at night time, given that we can't get social care in the community for people overnight, at the best we can get 4 calls a day, half an hour, 2 carers, unless somebody's in the last couple of days of their life. And the last call is likely to be 9, 10 o'clock. So that person will be up to 12 hours without care. There is nothing more stressful than facing a wet bed every morning if you're a carer. I have a disabled son, and for various reasons, at the age he is now, he doesn't want to wear containment products. You can bet your bottom dollar the days when I've got to go somewhere, 5:30 train from Sheffield, he will wet the bed and I will want to kill him. As much as I love him, going to a wet bed in the morning when you have other things to do is a massive source of stress. And that's often the thing that breaks the camel's back so the carer can't cope. And these patients often present in crisis because of that. If you go into 24-hour care, any independence that you have may be lost, and you'll become increasingly depressed because you're there when you didn't need to be. And the paradox is, if you're wet in a care home, and there's lots of data from America that's been duplicated in the UK, the staff don't like you as much as the patients who are dry. So you've ended up in a care home because you're wet at night, and then when you're there, the staff will perceive you in a more negative way. So that's an awful lot of misery that we inflict on everybody for something that's a treatable condition. And if that was serum cholesterol, there'd be a national outcry that we weren't doing for it. And most people don't wake up every morning thinking of what their serum cholesterol is. But they do wake up every morning worried about that they're wet. So if we embrace all this, if we go back to say it's functional disease, if we consider the biopsychosocial model of disease, which is part of comprehensive Jericho assessment, then yeah, we have an obligation to at least seek the information out on how to treat this. So what happens when you wake up? Well, most people don't think about the cholesterol and they don't think about the blood pressure. They think about if they've got a good hair day or a busy diary. If you wake up in the morning and the bed is wet, do I smell? Do I smell today? Is X, my carer, going to cry or shout at me? Already you're building up the day that actually somebody you care about, you're going to cause them stress. So, of course it affects quality of life being wet. How can it not? It also means that you have less social interaction and sexual interaction at any age. So if you're wet at any age, and you know, all of us here who treat old people know that old people do have sex, you know, possibly more than I have in my life sometimes, but yeah, they do, and they do perceive themselves as sexual beings, and it does affect their sexual attractiveness, and that happens at all age, whether you're wet at 30 after a baby as well. These patients have more depressive cognition about themselves. They tend to be more negative about their ability to do most things if they're wet. And the greater stress and burden does lead to carers' negativity and often presenting at crisis point. Well, what's keeping dry about? It's about non-bladder things, which is why it's the remit of general physicians and general practitioners and not urologists and gynecologists. You have to have the desire and the motivation to stay dry. If you have things that affect the parts of your brain that are allowed to perceive you being bothered about being wet, then you become incontinent more early. You have to be able to find the toilet. That is ridiculously difficult sometimes. If you go back to the places you work and look at the signage, it's likely that you have a stick man or woman and an arrow. Now, that just means stick man and woman walk that way if you have cognitive impairment. It doesn't mean the toilets are that way. There's nothing about that says toilet in a functional way. So in my hospital, we have signs that say toilet in big letters with a picture of a toilet, and it's very explicit where they are. And there's very, very good evidence in patients with cognitive impairment that will improve dryness, and these things aren't expensive. The Alzheimer's Society sell them for non-profit. To kit out a whole ward will cost you something like £52, which is probably what you spend on one person's pads in the day. You have to be able to get to the toilet, and if the toilet is further than you'd normally mobilise, which is something else we do in hospital, then that's against you being dry. You have to remove your lower body garments. If you have functional impairment with your fingers and you find buttons difficult, then putting somebody in buttons makes the time that they've got to actually stay dry before they void hard. Then you sit down on the toilet, and then you void. So it's only then that we're actually in the remit of our urology and gynecology colleagues. The rest of the things that are involved in keeping dry are actually part of functional geriatric assessment. So, what are we aiming for when we treat this patient? Well, we're aiming for social continence, which might not be absolute dryness. You can get these patients dry, but more often than not, when you ask them what they want, it's about goals that improve their social life. And again, that's about non-bladder things. Continence is a learned response, and you can unlearn it by being demotivated because of things that may happen to you if you wet in hospital because carers don't get to you, or we put a catheter in and you have some bladder instability after the catheter. You have to avoid in a socially appropriate place at a socially appropriate time. Now, I got asked to see a patient in a care home who had very advanced dementia, and he would get his willy out and pee anywhere where he saw white porcelain. Now, that man wasn't incontinent, he wasn't socially continent, and the fact that the crockery that they used at the breakfast table was white porcelain was upsetting the man who wasn't as bad as him because he used to pee in his cornflakes. Now, that man didn't need a catheter, they needed to change the crockery for the table that he sat on, and hallelujah, it worked. He still peed in the flower pots, but the aspidistra liked it, so they weren't quite so bothered about that. So it might be that better enough to be able to stay in that care home is a better outcome than things like voided volume, which we tend to be beloved in clinical trials, into void volume and voided volume, and we just don't talk about that. Patients don't come to clinic and say, thank you, Dr. Orme, I now pee 350 mils where I used to pee 50. They go, thank you, I can now go to bingo. I don't think I smell anymore. Will you discharge me, please?